start just in a minute.
We are live.
A very good evening, everyone. Welcome to iFocus Online, Lecture 220, number 7 from the Squint and Paediatric Ophthalmology series. The topic for today is near vision complex, accommodation, convergence, and pupillary reaction. And we have with us Dr. Gunjan Saluja from Bhilai. I request Dr. Pradeep Sharma, sir, to please welcome her and to introduce our speaker for today.
Thank you, Shefali. I think it's a great pleasure to introduce Gunjan to give us this 7th lecture in the series of iFocus Online on Strabismus. It's a great pleasure because she was our student in RP Center AIMS and one of the brightest students, I must say. Even as a junior resident, then as a senior resident, she was in our unit, and it was always a pleasure to have her interact. And so her interest in strabismus is really very good. And I'm sure she's going to share with you some of the very, very intricate things which are very difficult to understand in this topic that she's covering today, the near vision complex. So as I said, she did her MD ophthalmology from RP Center AIMS, and then she has been an active executive member in EOC. And right now she is in Bhilai, and she's a consultant at the Advanced Eye Care Center, Bhatia Advanced Eye Care Center. She has 50 publications. She has 12 awards to her credit. So for a young age, she belies that. And I'm really proud of her achieving so much and much more. So I wish you all. So Gunjan, please, the stage is yours.
Yeah. Thank you, sir, for the introduction. And if the screen sharing can be stopped, I'll start sharing my screen. So, good evening, everyone. Today, I'll be talking about the near vision complex, which includes accommodation, convergence, and pupillary constriction. So what is accommodation? Accommodation is a process by which the refractive power of the eye is altered to ensure that a clear retinal image is formed. The purpose of this process is to focus the diverging rays coming from a near object onto the retina. Now, how does this take place? There have been various theories of accommodation which have been put forward. Remember, I'll be discussing in brief about all the theories, but the basic mechanism or the basis of all these theories is that the ciliary muscles are going to contract and the lens is going to become more convex in shape. But how does this occur and why is it so? So the first theory which I'll be dealing with is the Kramer's theory. So according to this theory, whenever the ciliary muscle contract, it is going to compress the vitreous against the posterior crystalline lens. And because the iris in front resists the pressure, this causes only the interior surface of the crystalline lens in the pupillary area itself to increase in curvature. Then the Muller's theory is similar to the previous one. It states that the contraction of ciliary muscle, mainly the circular muscles of the ciliary body, pulls the vitreous forward, and this further causes the lens to move forward and thus increases the lens power. Now, the most accepted theory is the Young-Helmholtz theory, which was first given by Thomas Young and was further elaborated by Helmholtz. According to this theory, in the accommodated state, the ciliary muscles are going to contract. As we can see in this image, the ciliary muscles contract and the zonules are laxed. And it is because of this laxity of the zonules that the lens is becoming more convex in shape. Why is the lens can change its shape to more convex? It is because of the lens capsule being an elastic one, and the role of lens capsule was further elaborated by Fincham in 1937. According to Fincham, during accommodation, the thicker ring of the anterior capsule surrounding the central region contracts, and the central capsule being thin bulges, thus causing a higher refraction. Then came the Sachar's theory, which is another accepted theory, and it takes a mention in our books. So according to Sachar's theory, whenever the ciliary muscles are going to contract, it is only the equatorial zonules which are under the tension, and the anterior and the posterior zonules are acting only as the support system of this, as a result of which the central surface of the crystalline lens steepens and the anterior posterior diameter of the crystalline lens tends to increase. Because of the laxity of the anterior and posterior zonules, the peripheral surfaces of the lens flatten. So the basis of this was that only the ciliary muscles contract and only the equatorial zonules are being tensed. Otherwise, the anterior and the posterior zonules are just acting as a support system for it. And it is because of this division of forces that the lens is getting steeper in the central portion, and the anterior posterior diameter of the lens is increasing. Then the Coleman's theory again says that the ciliary muscles contract, and because of that, the pressure in the vitreous increase and aqueous decrease, as a result of which there is a gradient which is created, and that acts as a hydraulic shift, and that hydraulic shift causes the steepening of the anterior lens curvature. Now, the Gallstrand's theory is another one which states that the elastic forces of the choroid makes the restoring force to the ciliary muscle, and the lens again being thicker at the peripheral surfaces than in the central polar surfaces, it becomes more steep in the curvature as compared to the peripheral surfaces. Now, Johnson's theory states that there's a circumlental fluid which is present between the equator of the lens and ciliary body. And it is because of the compression of this fluid in the circumlental space that there's a bulging of the anterior lens surface and further anterior movement of the lens. So we now saw that all these theories state that the ciliary muscles are going to contract. Definitely they are contracting, and your lens is getting more convex. But what is the force which is causing the lens to become more convex? Either it is the back force of the vitreous which is causing it, or is it because of the zonules which is causing the same? But how does this occur? When do we accommodate? So the stimulus for triggering of the accommodation pathway is the retinal blurring of the retinal image, following which the stimulus is carried through the optic pathway into the occipital cortex, striate cortex 17, and there are projections into the parastriate cortex, area 19 also, following which the efferent responses are generated and they travel through the midbrain, through the ciliary ganglion, and then further supply the ciliary muscles. In between the convergence, now we will be next dealing with convergence, and then I'll be telling you when the convergence centers are and how they are related. So near point, what is near point of convergence? So near point of convergence is the nearest point up till which a person can see the objects clearly, and beyond which the person has blurring of image. So it is a function of age, and it varies according to age. So at 10 years of age, it is approximately 7 centimeters. And as your age increases, the near point of accommodation further increases or recedes back. That is at around 40 years of age, it is 25 centimeters. At 45 years, it's around 33 centimeters. The far point of accommodation is the farthest point at which the smallest object can be seen clearly. And for emmetropes, it's infinity. And for hypermetropes, it's behind the eye, and for myopes, it is in front of the eye. The range of accommodation is the difference between the far point and the near point. Means the point up till which you can see clearly and the point up to which you start having blurring is the difference between the two and is the range of accommodation. Now, how do we measure accommodation? So accommodation is measured in diopter. Diopter is which is basically the reciprocal of the fixation distance measured in meters. So for example, if the fixation distance is 2 meters, so the accommodation power will be around half diopter. how can we measure the near point of accommodation? So there is a RF rule, that is Royal Air Force rule. It's a 50 centimeters long rule, and it is marked in top in centimeters. And on both the sides, there is diopters are measured, and diopters are mentioned, and according to the corresponding age groups. So there is a sliding target which has the optotypes. 6'9" is the sliding is the size of the optotype of the sliding target. So patient is asked to wear the full correction, and the rule rests over the malar prominence. The target is slided until the closest point is found at which the target is seen clearly. So amplitude of accommodation is the difference between the diopteric power which is needed to focus at near point and far point. So basically, it's the difference between the far point and the near point measured in diopters. So suppose if your near point of accommodation is 25 centimeters and far point is infinity, then the diopteric power needed to focus at near point will be 4 diopter, because see, we have to measure the power of accommodation is measured in meters. The distance has to be measured in meters. So it will be 100 by 25. So that will come around 4 diopters. And the far point will be infinity. So it will be 0. So amplitude will be 4 diopters. That is the difference between the near point and the far point in diopters. Now, disorders of accommodation, the most common of which is presbyopia. It's the physiological insufficiency of accommodation leading to progressive fall in the near vision. And there have been again theories which have been there, and the common causes attributed to presbyopia are the age-related changes in lens, which could be because of the decreased elasticity of the lens capsule, the sclerosis of the lens, age-related decline in the ciliary muscle power. However, we also come across some things like premature presbyopia when it occurs at the age before 40 years of age. So it could be because of uncorrected hypermetropia, premature sclerosis, and general debility. Now, other disorders include ill-sustained accommodation, which could be because of general tiredness, accommodation inertia caused because of increased reaction time. The patient will complain, in these cases, the patient will complain that when I am seeing the near object and then when I'm changing my focus to the distant object, for some time, I am not able to see the distant objects. And that is what is because of the increase in the reaction time. Then there is paralysis of accommodation, which could be because of third nerve palsy or because of internal ophthalmoplegia caused because of diabetes, syphilis, or meningitis. Similarly, as now we talked about the ill-sustained and the weakness in accommodation, there can be another thing which is excessive accommodation. So it is within voluntary control, and it's an intermittent process seen usually in young hypermetropes, myopes, because of excessive near work and working in low illumination. Accommodation spasm, on the contrary, is involuntary and is caused because of the excessive usage of drugs like miotic pilocarpine, hypermetropes, iridocyclitis, or in patients with encephalitis. So recently I came across this case. A 20-year-old had presented with headache and blurring of vision. She had discomfort with her glasses, and the glasses she was wearing was around -6 in the right eye and -8 in the left eye. The power was prescribed to her by a local optician, and she was not using her glasses since last 2 years. The previous one which she was wearing, she was not using since last 2 years, and that this was -6 and -8 with the recent power which she had got. So I repeated the undilated autoref, and it showed -3 and -4 diopter sphere. And it was to my surprise that she was having glasses of -6, -8, and now my AR is showing -3, -4. So I performed the cycloplegic refraction, and then the refractive error was found to be only -1 and -2. And she was finally prescribed cycloplegic refractive error after the post-Medriatic test. So these things are very common in practice because patients are not using glasses for a long time, and this causes pseudomyopia, that is a false, false excessive power or excessive myopia. It is caused because of increase in the ciliary tonus, eye strain. Usually patients will have, history of studying for long hours. They might have exams approaching and long screen use, which is common in this era. Now coming to the next part of the lecture, that is convergence. So convergence is a vergence adduction moment that increases the visual angle to permit a single binocular vision during viewing. So there are two types. Either it could be voluntary or it could be reflex. Again, reflex convergence can be tonic, accommodative, fusional, or proximal. So what is tonic convergence? Tonic convergence is because of the inherited innervational tone of the extraocular muscles and is important in determining the position of person's eye. Whereas accommodative convergence is, whenever we are accommodating, a given amount of convergence is also taking place. Stimulus for this is also the blurred retinal image, and it provides the gross adjustment of the position of eye when accommodation is taking place. Whereas fusional convergence is stimulated not by changes in accommodation, but by disparate retinal images, and it ensures that similar retinal images are produced at the corresponding retinal points, thus providing fine adjustment of the positions of the eye. Whereas proximal convergence is the one which occurs because of the awareness of proximity of the object. So whenever you feel like a object is approaching to you or coming close to you, proximal convergence starts acting. And that is one of the reasons why convergence in amblyoscope is more as compared to the prisms and cover test. Now coming to angle of convergence. So angle of convergence is the angle which is made between the two visual axes. It increases whenever there is an increase in the interpupillary distance, as we can see in the figure C. Here the patient has an increased IPD, and you can see that the angle which is made between the two visual axes is large enough. Or if there is a decrease in the fixation distance. So you can see that in figure A, where you can find that here is your object, and then the angle, it's quite near, and you can see that the angle which is made between the two visual axes is large. Now, as we discussed about near point of accommodation, far point of accommodation, range of accommodation, and amplitude of accommodation, we also have the similar things in convergence also. So first of all, dealing with near point of convergence. So near point of convergence is the closest point at which an object can be seen singly, or it's the closest point till which a patient can see a binocular single image, and beyond which they start complaining of diplopia. Far point of convergence is the relative position of eye at rest and is usually infinity. Range will be the difference between the near point of convergence and far point of convergence. Amplitude of convergence will be the difference between the far point and near point measured in diopters, or measured in meter angle. The analogy of diopter here is meter angle. So meter angle is the reciprocal of fixation distance in meters. It's analogy of diopter. The amount of convergence required for, so if you look at the definition of meter angle, it's the amount of convergence which is required for each eye to fixate at an object which is kept at a distance of 1 meter from the median plane. So for example, if you have an object placed at a distance of half meter, then the amount of convergence will be 2 meter angle. Similarly, if you have an object kept at a distance of 1 meter, then the meter angle will be 1 meter angle. So basically, it's just the reciprocal of your fixation distance. So if it's at 2 meters, the fixation distance is 2 meters, so the meter angle will be half. Now, how to measure near point of convergence? With the RAF rule, you can also measure the near point of convergence But here the dot is the target, and that target is advanced towards the patient till they complain of diplopia. Near point of convergence is around 8 to 10 centimeters and it remains stable. Unlike near point of accommodation, which was a function of age, near point of convergence remains stable. The distance closer to 5 centimeters is considered to be, excessive convergence, and a distance farther away, more than 10 centimeters, is considered to be remote. It can be as high as 25 to 30 centimeters in patients who are having convergence insufficiency. Now, coming to AC by A ratio. As we had discussed that there is an amount of accommodation, which is an amount of convergence, which is taking place with each diopters of accommodation, which is taking place. So there is an AC by A ratio. That is the accommodative convergence in prism diopters, which is taking place with one diopter of accommodation. So I think it is clear that with each diopter of accommodation, you are also doing some amount of accommodative convergence, and the ratio between the two is the AC by A ratio. So basically, it is used to evaluate patients, whether the patient's convergence is sufficient to the amount of accommodation which they are doing. Means if you are accommodating for one diopter, are you also converging for the same? Normally, it is 3 to 5 prism diopters, and AC by A ratio, nearly it remains constant throughout the life. Stimulus of accommodation itself causes convergence. That is blood retinal image, which causes the convergence and not the accommodation itself. So there are various ways to measure AC by A ratio. The commonly used are heterophoria and gradient method. Fixation disparity and haploscopic method are other methods which have been described, but their value in clinical examination is not very high. So coming to the heterophoria method. In heterophoria method, the deviations are measured at a distance fixation with full correction, and the deviation is then measured at the near distance. The near distance is 33 centimeters, so it comes around 3 diopters, okay? So AC by A ratio is further, it is obtained by the equation that IPD plus deviation near minus deviation for distance divided by the diopteric accommodation which is exerted. So that diopteric accommodation is 3 diopters because the fixation distance was 33 centimeters. So 100 by 33 is 3 diopters. For EXO deviations, the sign is plus, and for EXO, the sign is minus, which is used. Theoretically, the ideal AC by A ratio would be the point where the convergence requirement is fulfilled by the accommodative convergence and is equal to the IPD. That means whenever suppose if you have a near deviation of 30 prism diopters, and if you have a distance of deviation of 30 prism diopters, then they both cancel each other and AC by A ratio will be equal to the IPD. And that will be the theoretical ideal AC by A ratio. Coming to the next method, that is the gradient method. So here we are not changing the fixation distance. Here I'm not going to measure the deviation for near and then the deviation for distance. Instead, the distance remains the same. Instead, the amount of accommodation exerted will be changed by using plus or minus lenses. So for a given distance, minus lenses increase the requirement of accommodation, and plus lenses are going to relax the accommodation, because see, ultimately your accommodation was making your lens more convex. So if you are adding a plus lens, you are just aiding in the process, and they are going to relax then you need not require to accommodate, and the plus lenses are going to relax the accommodation, whereas the minus lenses are going to increase your requirement of accommodation. So here, the way we derive the AC by A ratio is that it's the difference between the original deviation and deviation with the lens, which is divided by the power of the lens which was used. So for example, for a given distance, if the original deviation was an exo deviation of 2 prism diopters, and then you inserted a concave lens, of -2, which gave you an ISO deviation of 8 prism diopters, then the AC by A ratio that will be obtained would be, again here the sign will be there of, because it's an exo deviation, the sign will be minus. So here the value would be 5 prism per diopters. That would be the AC by A ratio in this case. So gradient method, the way we use is the deviation with the lens minus the deviation without the lens divided by the power of lens which was used. Remember, if you look at the AC by A ratio, which is measured by heterophoria method, it is slightly more as compared to that of the gradient method, because in heterophoria method, you were taking the deviations for near also, and proximal convergence was coming into the role. Coming to the next method, which is the fixation disparity method. Here, AC by A ratio is calculated by two sets of data, where one set of data is determined by forced convergence using base in or base out prisms, and the second set of data is determined by altering the accommodative stimulus with a concave or convex lens. So it can be done by, see, the subject is given to is viewing two centric case lines, where the lower line is the one which you have just fixed it, and the upper line is moved by one eye by inducing the convergence with prisms or by using the lenses. And the patient is asked to adjust the upper line till it is seen directly above the lower line. So such measurements are made for change in prism and lenses, and AC by A ratio is determined by finding convergence and accommodation to the same fixation distance, and it is plotted. The graphic method is done with prisms and synaptophore and measurements are made sequentially by adding a concave lens of from -1 to -4 diopter, which are increased with 0.5 diopter steps, and convergence is plotted against accommodative effort, and this graph gives the AC by A ratio. Coming to the third part of the accommodation, near vision complex, that is accommodation, convergence, and pupillary constriction. So pupillary constriction is the third part of the near vision complex. So whenever the fixation is changed from distance to near, along with accommodation and convergence, pupils also constrict. As we compare the pupillary constriction caused because of accommodation with the pupillary constriction which is caused because of the change in the luminance, the pupillary constriction caused during the process of accommodation is quite slow and tonic in nature. It is maintained as long as the near fixation is maintained. And when you shift the fixation to a distant object, pupils are slowly going to dilate. And this is all in contrast to the pupil reaction which you see whenever there's a change in the luminance. So it takes 10 times longer to come back to its original position than other pupillary reactions.
Thank you, Gunjan. That was a very tough topic you have covered so elaborately, and I'm so happy to hear you presenting again. Yeah. So we have few questions for you, and you can. We have Dr. Durga as our hot seat today. So if you have any questions for a resident point of purpose, and Dr. Durga, if you have any questions and if you want to interact with the speaker directly, you can use this opportunity as well. In the meanwhile, I'll put up the questions. How is AC by A ratio important in IDS?
AC by A ratio is important because IDS can be of different types as defined by Kushner's classification, and AC by A ratio, if it is high preoperatively during the workup, that suggests that patients will need a plus diopter lens in the post-operative period so as to avoid the presence of convergence, excessive convergence for near. Because see, if you look at the classification of IDS, it is either convergence insufficiency, true divergence excess, simulated divergence excess. So if there is a simulated divergence excess, means the deviation for distance is more than near, but when you put a +3 diopter lens, everything comes back, the deviation for distance and near becomes same. However, if it is a true divergence excess, even after patching or putting a +3 diopter lens, the distance, the exodeviation for distance remains high as compared to the exodeviation for near. And if your exodeviation for near is less, that means in the postoperative period, there is always a risk that the patients may have an exodeviation for near. So in those situations, patients might need a +3 add for doing or an executive bifocals to prevent the excessive convergence for the near.
Dr. Durga, did you get what she was speaking? Yeah, you are muted.
Yes, I got it. Yeah, I got it. Actually, I have a question. In practically, if we have to calculate AC by A ratio in a patient, so out of all this method which we saw, which one is preferable, practically?
The heterophoria and gradient methods both are practical because you are going to measure IPD in your squint workup. You are going to measure the deviation for distance as well as the deviation at 33 centimeters. So heterophoria method is possible. Similarly, gradient method is also possible. You are not taking into account the IPD in this case, but that if suppose your patient is a myope and he is using glasses, -2 glasses or -3 glasses, then the deviation with the glasses and the deviation without the glasses will give you, divided by the power of the glasses your patient is wearing, will give you the AC by A ratio.
Okay, yeah, thank you.
Add on, I mean, clarify, many people will question many a times, why is the IPD added in heterophoria and not in the gradient method? The simple thing is that in gradient method, you are doing it the same fixation distance. So your IPD doesn't come into question. It's not going to change. But when you are doing for two fixation distances, that means distance at 6 meters and then at 33 centimeters for near, your convergence for distance fixation is changed. That's why the IPD becomes important. So as far as the both of these are practical, but the reliability is much more on the heterophoria method. In the gradient method, it can be as reliable provided you give time for the accommodation to change or relax, converge or relax depending on the power that you have given. So many times you give a +3, but you need to give a time and the optotype in order to see that the accommodation actually changes. I mean, if you see in von Nuden, there is a description that there is a reflex and stimulus AC by ratio. So what you are changing is the stimulus, but then the response is also going to come in. So the response and the stimulus AC by ratio may not be easily matched if you don't give time enough. So that is the difference between the two methods. Whereas in the heterophoria method, you're only going by the distance and near, and you're not changing the lenses as per se. So I think that is a very valid point what Dr. Gunjan was telling you, that both these two methods are very practical. The other two, the graphic method and the fixation disparity methods, are more for research tools because these are more detailed. They will give much more detailed assessment.
Thank you, sir.
Dr. Amitava, how frequently do you include AC by A ratio in your routine squint examination?
I like to do that because I'm actually amongst residents and I want them to be sensitized to the importance of AC by A ratios. So I like to do that most of the time. But I also, because if the children are small, I also look at the near distance disparity. Little children don't, allow too much putting lenses and checking these things. So I do also concentrate in a, near distance disparity to see if 15 prism diopters or more estimate. When I suspect that there is a higher AC by A ratio, then I will be particularly keen if the child's age is in a cooperative age to get formal AC by A ratios done. The other thing is, I have an issue with this classification of divergence excess and pseudo divergence excess, because it makes me feel that the problem is more at a distance, where it's divergence. I feel somehow we need to kind of change the terminology, because it is the measurement at near, which is being less because of the accommodative convergence kicking in. That is the one we put the +3 lenses, and we allow the near measurements to expand to now be close to the distance measurement. So somehow we need to have a term which kind of puts the onus on the near variation rather than a divergence excess and a pseudo divergence excess. I don't know whether I've been able to put that across.
Basically what we are seeing is the difference between the distance and the near fixation. And because it will clinically confuse you with the divergence excess, because a true divergence excess would be one in which the measurements for distance fixation would be more than for near. And since in this also, it will always be a divergence will be more for distance fixation. So that's why it's called simulated divergence excess. In fact, I would prefer the term simulated divergence excess and not a pseudo divergence excess, which honestly gives you a feeling there is something pseudo. It's nothing. It is a simulation which is giving you, and the simulation is coming because of the two mechanisms, as you have seen in Kushner's classification, that you need to do with the patch test that will take care of the Scobie's phenomenon, which is now described as a Scobie's phenomenon rather than just a proximal convergence being there. So this Scobie's phenomenon is interchanging between the near and distance fixation, and so there is a measurement difference. But if you find after a patch also, it is still that you have a divergence excess still there, then you can put a +3 diopter, and that was described initially by Brown, and that was differentiating and another kind of divergence excess which is coming as a simulation. So I think the term used was because of this reason, that it's practically it's a divergence excess which is going to come up in your measurements. The near one is less and the distance one is more, so you would say that.
Yeah, thank you, sir. So just an extension to this question, we have one more question. Is there a real surgical difference in management for simulated divergence excess of ideas and basic ideas?
You're asking, but Gunjan, you want to answer?
As such, there have been ways which have been described, like single muscle resection can be done if you have a true divergence excess, if you have a true divergence excess, as it has been described by sir also. And secondly, the other way, if you have, even if your patient has convergence in the post-operative period, a plus lens can be added for the same. An executive bifocal can be given to the patient, so as there is no esotropia for near, which is much more dangerous as compared to the exotropia in children especially.
I think what the question was, is there a difference between a basic exotropia and a simulated divergence excess, which also becomes basically a basic exotropia? So actually the answer would be no. There is no difference between this surgery for a basic exotropia and a simulated divergence exotropia. What Dr. Gunjan is trying to say is that for true divergence excess, there is a different surgical approach, that you may either do bilateral recession, which is supposedly initially thought that it would be having more effect, but studies have shown that both bilateral recession versus an R&R gives you a same sort of correction for near and distance. So that's why there was a problem that these two divergence excess are difficult to manage. And one of the things which we have suggested and done is that you can do the Scott's procedure on lateral rectus. That is the combined resection and recession on the same lateral rectus, in order to induce more weakness of the lateral rectus for distance fixation. So it's a Scott's procedure which may be done. That's one thing. Or the other people have suggested that you may do the same amount of surgery as you will do for a basic exotropia, but then you can do either a plus correction of +3 in order to take advantage of the AC by A ratio and have that induced esotropia corrected, or you may do a Farden on the medial recti if you are doing the same surgery. So these are different surgical approaches to take care of the different near distance disparity cases.
Yes, because the simulated divergence excess is nothing but it's just the true one, but we just have to uncover it by either using a patch or by giving a plus lens. So that is then the pre-operative workup itself, we have to rule out whether it's true or it's in the simulated type.
I can see.
Yeah. I like to, when I'm discussing with my postgraduates, I call these chaps as masqueraders. They are, masquerading as divergent success. And, I tell them, you got to catch these chaps by either a patch or a plus lens. And then you will find out they're actually trying to trick you and trying to fool you. So I call them a masquerade.
Correct.
Yeah. So here comes the next question. If receding of near point of accommodation is considered to be presbyopia, should age factor be considered a primary factor, or should the working distance be given priority for presbyopic correction?
For the presbyopic correction, you have to take in account the working distance of the patient itself. Most of our patients, they have a working distance of around 25 centimeters. And whenever you are prescribing for presbyopia, always prescribe for the 2/3. Have 1/3 of that of the patient's accommodation power in reserve. So always prescribe for 2/3. Though there are charts which state that, for above 40 you prescribe them +1, then 45 years you prescribe them 1.5, but this is not so always, because you do have to take in account the patient's working distance as well as what is the amount of accommodation the patient has, and then prescribe only for the 2/3 of that, and let the patient have 1/3 in reserve, because overcorrection can again lead to asthenopic symptoms, which we don't want.
Correct. In addition, I think you have to take care that sometimes people may have two working distances. Some people who are doing, let's say, a stenographic job, so they read as well as type on the computer, and when they're seeing on the laptop monitor, then they have so these people have little more range to be given. So because for the computer, it's going to be more than 25 centimeters, it's around 40 plus. And for reading, it will be around 25 to 35 centimeters. So I think work-related distance should always be taken into account. And many a times you may have these patients who have been given bifocals, and they say that it's okay when I read the books, but whenever I'm doing my computer job, it's a problem. So then they say that I use the older correction, which you had given me a year back. So that is correct. You need less of accommodation for a little more distance or intermediate distance.
Also, sometimes there are people who are working in the bank, for example. Okay, UP, we have lost the light here, but I'm sure you can see me still.
Yeah, we can see.
So, people working at the bank, for instance, they need to read a piece of paper which is next to them. They go to type something on the screen ahead of them, and they may need to talk to a client who's standing a little above them. So sometimes they need trifocals, and again, the distances are going to be important for which to prescribe. Also, individual requirements, it has to be personalized. So I keep telling my student that if you have a tall head barber, he's got long hands and he can be quite comfortable for a further age to do the hair cutting. But a shorter barber may need his glasses more earlier perhaps, because that chap's head is much closer. He needs more accommodative power. He needs that presbyopic correction maybe earlier. So we've got to personalize it sometimes.
Yeah. Thank you, sir. If the patient presents with double vision at 33 centimeters in primary gaze and in reading position, how do we clinically address this situation?
You mean to say that the near point of accommodation and near point of convergence are the same?
No, repeat the question. The questioner is saying diplopia, double vision.
Yeah, if the patient presents with diplopia at 33 centimeters in primary gaze and in reading position, how do we clinically address this situation?
So your patient is complaining of diplopia at 33 centimeters distance. That means that is the distance beyond which, that is the near point of convergence for him. That is the reason why beyond that distance, the patient is having diplopia. And the other part of the question is that he is having blurring of vision also at 33 centimeters.
No, I think what they want to convey is they are having diplopia only when they are at near and not in the distance.
So I think the question basically needs to be highlighted for all, that basically we have two types of responses. One is the blur and the other is the double vision response. On the whenever you're checking for the NPC, as Dr. Gunjan also mentioned, you look for the lines being doubled. Whereas when you're looking for accommodation, you will see the blurring of the line. So these are the two different endpoints which will determine whether we are looking for near point of accommodation, in which blurring will decide, and the near point of convergence, where the doubling will decide. If a person has only a doubling, then it means it's purely a fusional convergence problem. Okay. But if he has both, then it means he needs accommodative convergence also to be given, and plus also a prismatic correction for the convergence which is less. So you may have to sometimes do induced, give the induced prismatic effect in your bifocals. People who have a poorer convergence may have to have decentered glasses in order to induce the prismatic effect. Okay. So, I mean, that we have to see individually. If a person has fusional convergence problem, many a times we give the same routine bifocals, but then ask them to do fusional convergence exercises. But if that is not working, then you may have to give a induced prism to correct this difference.
So for how long do we have to give those prisms? So can we taper them off later on?
Depends upon his ability to develop his fusional convergence. So that will be seen. So depends on the age of the person, his ability to do the convergence exercises. So, I mean, of course, I mean, the first thing is always to stimulate the fusional convergence. So here, one more thing I would like to add. Many a times when we are looking for convergence insufficiency, we also need to see another aspect, that is the convergence sustenance. So one is the near point of convergence being receded. Some people may have a normal near point of convergence, but they have a convergence sustenance problem. That means they cannot sustain that much of convergence for more than 40 seconds. So when we are looking for this NPC, we also need to see how long he can sustain. A normal person should be able to sustain at that point for minimum 40 seconds. If he is not able to sustain and he breaks, then there is a sustenance problem. Even these people, even though they have a normal NPC, they may have to be given fusional convergence exercises to improve the sustenance.
Can you please explain the concept of light near dissociation?
See, for the light near dissociation, one has to be very much thorough with how the pupillary reflex is taking place and how your optic pathway is going on. Okay, so light near dissociation simply is seen in situations like in Taves dorsalis, syphilis. These things can be found where the light reflex will be there, but the near reflex, that means the pupillary constriction when you are working for near, is lost. So that is what is the light near dissociation, and usually seen in the CNS infections or syphilis, which is there.
While assessing the pupillary reflex with torchlight on routine examination, how do we avoid inducing meiosis as a part of near reflex?
See, first of all, you have to ask the patient to look at a distant object, not to look directly into your torch. Because if they are directly looking into your torch, definitely there will be a component of accommodation which is also going to come in. So ask them to look at a distant object, and secondly, preferably do it in a dim light room and place a palm or a partition in between so as to check the reflex whenever you're checking a pupillary reaction.
Better is to use an optotype for fixation and not a torchlight for fixation for this. And you should have a diffuse light to see the pupil from the side. So when you ask him to look at distance and then at a near optotype, the accommodation will come in and the meiosis will come in. So this is going to be there without the light being there, and you're just seeing from the side, diffuse light, what is the change in the pupillary reaction. So rather than shining the light in front of the pupil, it should be coming from diffuse, which you can see the pupils. And the fixation target would be from distance to near, and use an optotype for that.
So, Asha, it is also interesting to observe, if you go back to Hutchison and see what Hutchison says about checking pupil reactions, it just says you cover the eyes and then you just remove the cover and, just see it under that diffuse light, the reaction. They're not even talking about torches and things like that. Of course, it is important that you don't stand in front of the patient, So you need to be on the side. You have to encourage them to look at a far distance object so that their accommodation is not stimulated at all as far as possible.
Thank you, sir. Most of the time, pupillary reactions are regarded as sluggish in mentally unstable patients. So, is there any method that you can clearly tell what kind of pupillary reaction is it?
There is a grading of pupillary reaction which is there. And I think that is quite clear. And sluggish reaction is something which is quite a vague term. And usually it is written when you cannot judge out the pupil, but definitely there is. And secondly, there are pupillometers also there, which can help you to assess the pupillary reaction. But as such, a sluggish reacting pupil itself does not suggest, does not give a lot of information, and it's just a vague term.
The speed with which the pupil constricts also becomes relevant when we are having bilateral symmetrical problem. So, for example, if you have a toxic optic neuropathy in both the eyes, then you may not have an RAPD, because an RAPD is a relative afferent pupillary defect. So, in such cases, you will only see a sluggish reaction in both eyes. So, the speed with which it is contracting, that is important. If you want to do an academic workup on this, then a good tool that we have used earlier is the edge light pupil cycle time. Okay, so if you have the slit lamp and you shine the light on the edge of the pupil, then it constricts. The moment it constricts, it will the pupil will prevent the light falling into the retina. So then it starts dilating. Again, once it dilates, the light strikes the retina and it will constrict. So this is what is known as the pupil cycle time. And this will differentiate people who have abnormal pupillary reactions. And if you want to quantify, the edge light pupil cycle time is a good tool to see what is the responsiveness of the pupil.
But Asha, that question is very valid, I feel, because of late I've been seeing a lot of cases of cerebral visual impairments, and these special children not only have very difficult to assess them because they are very limp, they are not very cooperative. They also have hypo-accommodation, especially if they have the hypotonia. I've realized that they are hypo-accommodative also. And I suspect they may be also hypo-myotic also, in the sense, in terms of pupillary reactions. And I've now, for the last couple of weeks now, I've started carrying a +3, pair of spectacles, which I sometimes put on a child who's not, being able to see. And I've had one case where we put it on and the child seemed to brighten up his response, and as if he was being able to see things better. But yeah, it is a challenge.
Thank you, sir. Can you please elaborate on the types of convergence?
Types of?
Convergence.
So I had discussed that in my presentation also. It could be voluntary, it could be reflex, and then again the reflex have been divided into 4 types. They are tonic, accommodative, proximal convergence, as well as the fusional convergence. So tonic is because of the inherent tone of your extraocular muscles, which is responsible to keep your eyes at rest straight. Whereas fusional accommodative convergence is the one which is because of the accommodation. Convergence is also occurring along with that. And that is the accommodative convergence. That means the convergence which is taking place along with the accommodation. Then the fusional convergence is the one which is responsible for keeping your eyes straight and for maintaining the binocular single vision. And if you come for the proximal convergence, that is the convergence which is because of your feeling of the proximity of an object. So if suppose a pencil is approaching to you and you see that a pen or a pencil is approaching to you, your eyes tend to converge. So it's a convergence which occurs because of the feeling of proximity of an object. So that would be proximal convergence. So these are the 4 types of convergence, and these are the basis where the divergence and other divergent type of squint is occurring.
So proximal convergence in some books also has been mentioned as instrument convergence. So sometimes you'll find in the older books, the instrument convergence also being used as a term. The good example of a person having the accommodative convergence and fusional convergence disbalance many a times is a practical thing. I have seen some people who have been operating without a microscope initially, and then they switch to working on the surgical microscope. They come in and they say that I have difficulty in seeing the thing because everything becomes double. Now, here what was happening was that they were using the accommodative convergence in place of pure fusional convergence, and they were operating. So with loops and all, when you are operating, you will be able to converge because you are accommodating. But once you're using the surgical microscope, then it is making sure that you don't accommodate. You are using only your distance correction, and it is supposed to be parallel rays of light, so you're not accommodating. So then these people start having problems of double vision. So you put them on a fusional convergence exercise schedule, and then they are okay to work on the surgical microscope. So a practical thing, which sometimes you may encounter with some of the residents and fellows who have suddenly switched to surgical microscope, they may have a problem.
Thank you.
Asha, just one more thing. I like to talk about proximal convergence in the sense that even in darkness, if a person was asked to look at his thumb close to his face, he can't see the thumb in pitch darkness. But this sense of proximity will also induce meiosis. Okay, that would be, and convergence. That would be the proximal one, truly. If you had the infrared cameras to pick up the heat from the iris, you could see this proximal, response to both meiosis and the convergence.
So this is the last question for today's session. Can you please explain NPA measurement using the RAF ruler?
For near point of accommodation, you can measure it very simply by using a Royal Air Force ruler. It's around 50 centimeters long, and it has a rest which can rest on your malar prominence. It has a target which has an optotype of 6/9 size. And then the scale has the dioptric values of accommodation and corresponding ages on either of the sides. And you bring that target closer to the patient till the time they start complaining of blurring. The point at which your patient has started saying that, I'm seeing blur image, the 6/9 optotype is blurred now, that is your near point of accommodation.
So I really like the way you always give the full form of RAF, or to go such bookish whenever you want to explain anything. Malar prominence, Royal Air Force. Yeah, thank you, Gunjan, for such a great lecture, and thank you, Dr. Pradeep Sharma, and thank you, Dr. Amitava. It was such a pleasure having you on the panel, and I feel very privileged to share the panel with all of you. And thank you, Dr. Durga. You have been a very good hot seat. And thank you, Shefali, and thank you, Subhash and Deepti. So we will be meeting in just a second. Yeah. We'll be meeting next on July 20th on Wednesday. And the topic will be Sensory Science and Binocular Adaptation in Strabismus by Dr. Savin.
Thank you, Asha. I think it was very nice session. And I just recollect, I think Dr. Amar Pujari is working on ASOCT and seeing the accommodation changes which is happening. So I think, I don't know if he would have published that part. He was working on that, I remember lately. So that's objectively now you have the tools you can see on the ASOCT. But long time back, it was Dr. Patnaik who had worked in, I think, Hungary or somewhere. That picture he had taken on this slit lamp, and that is in Duke Edell's book also. It's with his name. So Vijayanand Patnaik, and he had worked in that, and he had taken the difference of the lens size being changed. So earlier we were doing with the optical measurements, but now you have good tools to measure the change in the thickness of the lens, and the ASOCT nicely shows you the changes which happen with the AC depth and the thickness of the lens. So for all of you, I think you have good tools to work on, and you can do more research and more interesting things. So once again, thank you, Asha, thank you, Gunjan, thank you, Dr. Amitava, thank you, Shefali and Durga. It was really good to have you all. Thank you.
Thank you, sir.
Thank you.